The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. We are live tonight from the studios of ACTN. It's Wednesday, the 10th of May, and we're going to be talking a very interesting topic tonight. I just want to say at the very outset, usually my dear wife Linda is with us, but you're going to have to cope with my face tonight. And I want to wish in advance all the mothers a happy Mother's Day coming up on Sunday. As you know, this program is replayed, so if you're looking at this program next week, you would understand why I'm wishing all our mothers a happy Mother's Day. Well, tonight I'm very pleased to have Dr. Anil Ramlackhansingh with us. Anil, thank you very much. Good to have you on the program.
Thank you for having me.
Anil, you are a specialist neurologist.
That's correct.
And I met you a few weeks ago, and it was great getting to meet you, and I felt we had not really talked about neurological problems on this program. So just tell me a little bit about yourself and your training, where you were trained, where you did your undergraduate degree, etc.
Well, my undergrad training was here in Trinidad. I'm a graduate of UWI.
Right.
Back in 2000. In 2002, I went up to the UK, and I've been there for about 14 years, came back just last year.
Right.
Up there, I completed my training in medicine, got the MRCP, and then went on to do a PhD, and then training in neurology, completing training there, and now back in Trinidad, working as a specialist neurologist.
Right. So you, interestingly, I mean, I'm very impressed with your qualifications. Your PhD in neurology. What was your area of research?
A lot of my research in my PhD had to do with dementia and dementing processes.
Right.
And I was using specialist scans to try and better identify and try and figure out what was going on in the brains of people with different forms of dementia.
Right.
Whether that's Alzheimer's dementia or Parkinson's dementia or dementia because of traumatic brain injury.
Right.
Which is quite prevalent.
Yes.
So really we were looking at inflammatory processes and changes in the brains of these people using specialist scans.
Right. And this PhD was at Imperial College?
Imperial College.
Okay, and that's quite a difficult college to get into, I would think. So congratulations. I mean, I, as I said, when I met you a few weeks ago, I was very impressed with your qualifications. So can I ask you a kind of personal question? What made you come back from the UK to beautiful Trinidad?
To beautiful Trinidad. I think at the end of the day, Trinidad has a lot of potential.
Right.
And there's no denying the fact that there's a lot of work to be done in Trinidad. And, I always think of it that one of Trinidad's biggest exports is talent.
Right.
A lot of people do go away. And it's true as well that a lot of people are returning to Trinidad.
Mm-hmm.
And I hope that the country itself will benefit from people coming back. And that is one of the main reasons I'm back here.
From our time, which is way before yours, a lot of my colleagues went to the UK, a few went to the US. What we generally found is that people who went to the US tended not to come back for whatever reasons. But a lot of us who went to the UK eventually came back to Trinidad. And I guess expectations are very important, because when you have spent that amount of time in the UK, in a first world country, would you have to adapt? I mean, the last year, have you had to adapt your expectations?
You do have to adapt what you believe you will encounter, but I don't think you should change your expectations in the sense that you should expect that a certain level of treatment is achieved.
Right.
You should expect to treat people correctly. and along with that, you should expect that you are treated correctly. And I have to say that being in Trinidad, my experience thus far has been that people are treated in a generally good fashion. And likewise, the feedback I get from other colleagues and physicians is has been positive as well.
Right.
So I think that while it's definitely a different environment. Trinidad is not the UK. My expectations of what would happen have been sort of realistic as such. Yeah.
Excellent. So no regrets so far
No regrets
coming
so
back,
far,
and
no.
and you're escaping the damp, wet,
Oh, definitely.
Right.
Yes,
which actually is one of the reasons, as I mentioned to you, we spent about 15 years in the UK, and one of the things was getting away from the winters. Anil, I wanted to just kick off the discussion talking about you're a neurologist. And I think there's a little bit of confusion amongst the viewing public very often, patients coming in, the difference between a neurologist and a neurosurgeon. How would you define the major differences between those specialties?
And I have to say, I do get this question at times from patients in Trinidad and in the UK, in fact. Neurologists are not the same as neurosurgeons. Neurosurgeons have very difficult decisions to make about operating on people, and operating on people with lesions or abnormalities in the brain,
Right.
spinal cord, nervous system. Neurologists are medically trained, and we are better skilled at the art of diagnosing and managing medical conditions that go wrong with the nervous system.
Right.
For example, excessive inflammation, epilepsies, headaches. A lot of these things fall under the realm of the neurologist. And occasionally we do have to ask the neurosurgeon to intervene if we do find something that requires surgical intervention. The job of the neurosurgeon is not trivial at all, and it sometimes it's you see a lesion there that you would love to touch, but you
Right.
dare not because it's in a very tricky part
Yes.
of the brain. And I really don't envy some of the
Decisions.
things that they have to do.
Yeah.
And it does require a lot of skill, I have to say.
Yeah. But I think it's very important for our viewing public to understand the difference. So I think that's important the way you have defined it. Similarly to myself, I'm a physician, so I don't operate. I don't touch a scalpel. If, like, even today, someone came in with a diabetic foot ulcer, and my job is to manage their blood sugars, etc. And then I have Dr. Beam, who works with me, consultant surgeon. So hopefully people will understand the differences. So what I wanted to get into, and I just want to remind the viewing public that later on you can ring us on 652-4855, 652-4855, and especially tonight we want you to stick to neurological problems, but we will take questions after our first break. Anil, I wanted to kick off talking about non-epileptic attacks. Now, when I was preparing for this program, I have to say it was a little bit of a revelation for me myself. I had to do some reading about this. So let's just talk a little bit about what we mean by non-epileptic attacks.
So to sort of illustrate what this condition is, I just want to take you through a story. Let's so a patient comes to me in the office, a young lady, and she said she comes in having seizures, and so the decisions I have to make: is this epilepsy? Has she had a seizure? Has she had a convulsion because of another reason? And you go through this story with her. And a lot of times, again, the skill of the neurologist is really in taking the full story from the patient. And then you realize there are other things going on in this person's life. And a lot of the attacks that are taking place are quite bizarre and not really typical for epilepsy-driven seizures as such. And what I mean by that are actual seizures driven by abnormal brain activity. And so then you have to figure out, well, what's going on here? This doesn't sound like epilepsy, these attacks are actually provoked by stress and stress factors in the person's life. And this is where the whole sort of story of the non-epileptic attack disorders come into play.
Anil, you know, we live in a culture where we have to be very cautious. Sometimes patients come in with symptoms and we start talking about stress, and we start talking about emotional aspects. And I would say as a culture, we're not often very comfortable talking about, you know, patients very often want a purely medical explanation.
Yes.
So with this kind of scenario, I mean, in your experience, are they common? Are you seeing quite a few patients coming in with non-epileptic?
You know, they to get an actual figure on how common these attacks are is actually very difficult.
Right.
And the reason is that a lot of times people are misdiagnosed as having epilepsy. And I think the thing that you have to emphasize to people is that in order to treat people properly, you need the correct diagnosis initially. And you know, it's really a matter of sitting down and talking with people and explaining things through, that you get the full story about provoking factors which tend to be stress related. And a lot of times, you know, people will tell you, look, I don't feel stress at all. You know, what you're saying here is complete nonsense. You know, how could you tell me I'm stressed? I don't feel stressed. But you go through the story that they come in with, and you sit down and you talk to them. And you have to sort of explain that actually the way that their body is dealing with the underlying stress factors is by having these attacks. So you may not actually feel consciously stressed. In fact, you might feel fine.
Yes.
But this is how you're managing your stress, is by having these attacks. So it's really something that they require to work through and to manage appropriately, really. And what you don't want to do, and this is something you have to explain to people as well, is that you don't want to treat people inappropriately.
Right.
Epilepsy drugs are not trivial. A diagnosis of epilepsy is not trivial.
Yes.
And you know, epilepsy drugs are not going to help non-epileptic attacks. It may just have you feeling pretty rotten during the day. So it's something that you have to be very clear about with people.
I'm not sure what the regulations are like here in Trinidad, but of course in the UK, a diagnosis of epilepsy, and we will come on to talk about epilepsy, but if you give someone that diagnosis, there are implications in the UK at least for driving and going up heights. Am I right?
Yes, that's correct. There is a driving, the DVLA in the UK association that you need to, it is reportable. It is the responsibility of the patient in the UK to report this diagnosis. It is, you should do that here in Trinidad as well. There are implications in the UK in terms of chronic illnesses, and everything from your job to your mortgage can be affected. So it's not a trivial diagnosis at all.
Yes. So how, I mean, taking the history is obviously very, 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 very common, very important, but how is it actually diagnosed? How do you make the diagnosis?
We go back to history.
Right.
We do go back to history. The whole story in the hands of a neurologist, they can tweeze out the facts that make you think these are non-epileptic attacks. The attacks can be very unusual for epilepsy. They're not like epileptic attacks at all. They may or may not be provoked by stress factors, in fact. So the history has a big part in guiding what tests or what investigations you're going to do. Because your suspicion is really going to come out from that description of the attacks.
Right.
And bizarre and unusual tends to be the key factor here. So then you go on to, okay, so what tests do you need? So there are obviously tests that can be done looking for abnormal electrical activity in the brain. I'm referring to the electroencephalogram, or EEG.
EEG, right?
Commonly known as a brain wave test, looking at, you know, electrical activity in the brain. And if you can capture one of these attacks, if they happen frequently enough, while you're having an EEG done, you can demonstrate that actually the brain itself is working normally. There's no aberrant or abnormal
Right, okay.
electrical activity going on.
Can I ask, are EEGs easily available on the government service and as opposed to the public sector?
So as
EEGs.
EEGs. So I mean, you can get EEGs in the public sector. Obviously, they are easier to get in privately, but no, they are available, but less
Limited.
Yes.
Okay. Yeah.
And you know, there is a element there. You have to choose carefully who you're going to get EEGs done on.
Yeah.
And then you can go on to say, well, you know, do you need to do imaging of the brain? Do you need an MRI or a CT scan in all of these people? The answer in the majority of instances is that you don't technically need such expensive or invasive imaging to be done. But it is very useful to know that structurally the brain looks normal as such.
Right. Okay.
But really, the history is what is the
key.
story is the key feature here.
I think it's interesting that you're coming back to history taking, because my experience with the my UK training was that, again, you know, I would often say to younger doctors who train with us that one of the things I learned was not so much more medicine, but a lot about consultation styles and the ability to elicit that kind of history taking. And I step on toes all the time, so Anil, you don't have to step on any toes. But a common complaint from some of patients coming in is that as doctors, sometimes we are not willing to sit long enough to take that history. Now, admittedly, in the government service, very often our clinics are large, especially for primary care physicians, and it's often difficult to spend 30 minutes with a patient, whereas in private practice, you know, you may have a 30 to 45-minute appointment. So very often there's that dilemma, being able to spend, at least in the government service, sufficient time.
I think the way that you can work with that really is to try and tease out the people who are not responding well. So you know, so the government service obviously is very stressed. You've got a lot of people to see in a limited time, and you have other duties to fulfill as well. So really, you know, so epileptics, they should respond to treatment, but you've got a subgroup of people who are just not helping, and these are the ones that require perhaps a bit more time to be spent with them and looking into their issues to a greater extent. It's always very interesting what people sort of say about us and as doctors, and it is a shame that a lot of times we just don't have sufficient time to get the whole story.
Anil, we, believe it or not, we've been talking for about 20 minutes already, so we have to go to our first break. We're going to go to a break. When we come back, we will continue with Dr. Ramlackhansingh talking, our neurologist, talking about non-epileptic attacks, and maybe about halfway into that second segment, you'll be welcome to call in. So we'll go to our first break and return in about 2 minutes' time. Thank you.
Tsunamis are rare, but they can be extremely deadly. In the past 100 years, more than 260,000 people have perished in 58 separate tsunamis. At an average of 4,600 deaths per disaster, the toll has surpassed any other natural hazard. As a result, the United Nations has designated the 5th of November as World Tsunami Awareness Day and called on the world to mark it. Visit the ODPM's website and social media pages to learn more and be part of our tsunami awareness activities.
this world, the eyes have it. And that includes Ferguson's Optical, bringing to you eyeglasses, contact lenses, and sunglasses. We have the latest styles and frames to match any budget, including free frames for seniors. Ferguson's has your eyes covered for the best prices in 4 convenient locations. Come see us at 100 High Street, Princestown, 39 Bonaventure Main Road, Gasparillo, 4 Clark Road Junction, Pinal, and number 2 Junction, Barrackpore. For more information, call us at 369-1650. We are Ferguson's Optical.
Welcome to Privé Restaurant and Conference Center, tucked into the lush hillside, surrounded by a picturesque landscape. Our patio is an elegant area suited for any family or corporate event. The dining room features subtly sophisticated decor. The flamboyant room is a private conference facility, comfortably seating 20 persons. The iguana deck features earthy elements, and our courtyard is unlike any other in the South. Privé, enjoy the moment, savor the meal. Call 653-4760.
Oh, welcome back to Your Health, Your Choice. It's Wednesday, the 10th of May. Remember, this program is replayed on Thursdays at around 1 p.m. and Sunday evenings at 7 p.m. And again, my dear wife, is not here with us tonight, so I'm taking the seat of interviewing our guest. So we've been talking about neurological problems. Dr. Anil Ramlackhansingh, it's good to have you on the program.
Mm-hmm.
And we were talking about non-epileptic attacks, which is quite an intriguing area. And we talked about the investigations. What are the treatments for this, what I suppose must be a difficult problem?
It is a difficult problem. And the thing is, the first part is the treatment, is explaining the diagnosis.
Right.
So it's never an easy thing to sort of give people this diagnosis, really. And really, the important thing is to emphasize that this is not epilepsy. Their brain functioning is actually normal. But really, the treatment options here are largely involve behavioral therapies to better help people cope with the triggering factors, which in a lot of instances are stress-related. So it's rather than dealing with the attacks, in dealing with stress, it's rather sort of redefining that and finding different ways to behaviorally adapt to the stress that is affecting people.
Mike, again, thinking back about from my years in the UK, I think people are quite open to thinking about that kind of treatment. You know, stress is something that's very much a reality. You know, jokingly, I say to people that when I was coming back to Trinidad, my colleagues gave me a little cake with 2 people lying at a beach, thinking I was coming back to go to the seaside and it's going to be a stress-free environment. But Trinidad, actually, I would say we are very stressed society. I don't know.
This is probably correct.
Right.
I think Trinidad is, you know, not your
Typical.
Caribbean island. In many levels, you know, it is there are a lot of expectations in this society, and yes, people do get very stressed, and this can be a manifestation. So it's really reteaching and educating one's own body and how to deal with the stress. And a lot of the therapies, I mean, the technical names are things like cognitive behavioral therapies. A lot of it is talking through the things that are bothering you and things that might have happened in the past that are still undisclosed, and really bringing these things to light, really.
Right.
So these are the mainstay, or this is
treatment.
the mainstay for treatment.
Right. So really, there's no role for drug therapy in this particular condition.
There is no role for epilepsy drugs.
Right. Okay.
If you, people can be very anxious, in which case you might want to use anxiety type medications. Depressed people, depression type medications that would be needed. There's no role for epilepsy type medications here. So you do have to tailor your treatment for the person in front of you.
Right. Okay, so Anil, I want you to kind of move on now to what a lot of our audience would have heard about epilepsy. Very common topic, and I guess our family doctors would be seeing patients with epilepsy. How would you define the simple definition of epilepsy?
I think, an easy way to look at it is your brain is a very complicated network of nerves and nerve cells called neurons. And they all need to be functioning normally in order for you to think properly and behave properly and use your body in an efficient manner. Now, if you got a bit of that brain that's just not behaving itself, it's just not behaving properly, and it starts firing off on its own, and then it starts involving other networks and starting to encroach onto normal brain, and then because the brain isn't working properly, your body doesn't work properly as well. And this results in the shaking episodes that we see, and eventually the entire brain shuts down and is involved in this epileptic, abnormal electrical activity. And the whole, and the result is just a chaotic electrical functioning within the brain. The result of that is chaotic functioning in your body, and you do eventually lose consciousness, you lose your ability to think clearly, and you have an epilepsy-driven seizure.
Now, can you, when you say a seizure, what are we actually talking about?
So a lot of times the type of seizures that you commonly see on television does reflect the type of epilepsy that we call generalized epileptic attacks.
Right.
And by generalized, I mean the entire brain has gone into dysfunction, and the entire body as a result has tremors, there's abnormal breathing, there's biting of the tongue, you become very cyanosed, or you go blue because your breathing is impaired, and you may become incontinent of urine as well because your higher functionings, the functioning of the brain is impaired.
Right.
Your recovery from this episode is prolonged as well. The person can be very confused because the brain is trying to reorganize and regain control of itself. And the result is a phase after the seizure where the brain is trying to readjust and figure out what exactly has happened to itself. So that's the common generalized seizures that we see a lot on television or even in family members who are epileptics. But then there are the more unusual types, these types where only part of the brain is involved.
Right.
And the result is that you actually may not lose consciousness. The brain itself might still be able to function relatively normally, but yet a bit of it is triggering off. And the result is that only part of your body is affected. So you might find that part of the body is shaking in an abnormal fashion. You may find that you get abnormal feelings, for example, in a particular type of epilepsy known as temporal lobe epilepsy. Some people have a feeling of terrible fear,
right?
And they may have this rising feeling up in their tummy. So sometimes these events may not generalize to involve the entire brain, and they can be a little bit tricky to tease out as
No,
seizures.
I was just going to say that, Anil, because the typical grand mal seizure, that's fairly straightforward, I guess. But temporal lobe epilepsy, for example, could be
a little bit tricky, really. And sometimes these people end up having very bizarre behaviors. because of temporal lobe epilepsy. And you may find that they see a degree, other specialities. They end up with the psychiatry team, for example. And going, when the psychiatrists go through this story, a lot of times they think, look, this isn't quite depression, this isn't quite psychosis, this might be epilepsy, and they do contact the neurologist nearby to get their opinion on the situation. So, conditions where, you don't progress to this very dramatic, generalized seizures, these things can be very tricky to tease out.
Right. What are some of the risk factors for epilepsy? Are they clearly identified
risk factors that put you to greatest?
Yes.
Unfortunately, in today's lifestyle, does put us at risk as such, and of course the acute stress factors can lower your seizure threshold, especially in people who are prone to epilepsy.
Right.
Other things that can put you at risk include things like strobe lights, so bright lights, excessive video games with their flashing lights as well. Sometimes I take people back to what you might have heard in the 2012 Olympics in the UK, the advertisements they were using to popularize the Olympic Games. Then those flashing lights provoked a lot of epilepsy in people who were predisposed. Other things, low blood sugars from missing meals, drugs, for example, excessive alcohol, amphetamines, for example, ecstasy and cocaine, can also lower your seizure threshold, making you prone to seizures.
So would you have a predisposing, by the way, we're going to open up the lines now, 6524855, 6524855. So if you have any questions for Dr. Ramlackhansingh on neurological problems. Now, of course, we're talking about epilepsy and non-epileptic attacks, but you may have questions on headaches or strokes, for example. Those are the kind of questions we want to entertain tonight. So the number is 6524855. Anil, the point I was going to ask is, so you said these triggers will bring forth a seizure. So that patient would have had an underlying predisposition.
The people who have underlying predisposition, they're more at risk.
Right.
I should clarify.
Right.
Even in the normal population, if you take drugs or if you expose yourself to a lot of video games or strobe lights, in a normal person, that too can provoke seizures.
Right.
But obviously it's worse in a known epileptic or someone who has that potential there already. They're more prone to developing these things easier.
Right. Okay. So if we just move on a little bit to the we said we talked about the grand mal convulsion, temporal lobe. What are some of the other types of epilepsy?
Sometimes we like to name the type of epilepsy depending on which part of the brain is affected. So you'll hear doctors talking about frontal lobe epilepsies, where people have changes in personalities and a lot of motor activity. So movement is a big part of them. And occipital lobe epilepsies, the occipital lobe being the visual part of the brain. People can have very unusual and bizarre visions with these epilepsies.
Sorry to interrupt, Anil, but I think we have a call. So let's see if we can take our first call. Welcome to Your Health, Your Choice. Good evening.
Good evening to you, doctors. Doing a good job.
Thank you.
I have a certain concern about my husband. Over the past 15 years, he had had 4 strokes. One on the left side at first, then one on the right, then a speech stroke, and recently here, about a week ago, he had another stroke on the right side with a speech defect, and the right arm is painful. He's having a lot of headaches, and I don't know what light you can shed on that. I find it so strange that he could have 4 strokes and still survive. I mean, not that I wish anything bad on him, but I find it strange. Could you explain that for me, please?
How old is
very
your...
much.
How old is...
He is 79. 79.
79.
Right.
So, okay, well, to answer the first question, yes, someone can have 4 strokes. I mean, but obviously it's over a period of time. When did he have his first stroke, or is that his?
He may have gone.
They
May have gone already. Yes.
Yeah, I mean, it's unfortunate that this would have happened to somebody. Four strokes over the course of time, and it would suggest that the underlying, risk factors to strokes were not adequately addressed during this period of time. And the thing to understand, however, is that the part of the body that's affected by a stroke, when you do have an event like that, there is always potential to recover. So this is this is the thing. So he may have had a stroke affecting the right side of his body, but that if you don't address the reason that someone has had a stroke, with time, despite the improvement on the right side, let's say, you can again have another event involving that area again. And obviously we have to look at the risk factors for stroke, be that high cholesterol, diabetes, hypertension, smoking. If these things are not adequately addressed and the proper investigations done, well, I'm afraid this is what might happen, that you go on to have another event. Especially if somebody has a structural problem, for example, a heart abnormality or thickening of the blood vessels in their neck, which supply the brain. If these things are not properly dealt with and investigated, the end result is another event. And this bears to this emphasizes the fact that when somebody has a stroke, it is an opportunity to investigate that person and to really tease out why this event has happened and to initiate secondary treatment. Now I say secondary treatment because the stroke has happened already and we're trying to prevent another one from happening.
I'm going to just a little bit of a controversial area here because it's a little bit of concern that I have. We have so-called stroke doctors in Trinidad. And, we have patients coming in. When I initially came back from the UK, I would have patients coming in and they would say they would go to the stroke doctor and they would get 4 injections, 5 injections. And I would be intrigued to try and find out what were these things that's been injected, because in the UK we hardly gave injections for stroke. So I mean, this lady is obviously very concerned, and I know we may have to have a subsequent program just on strokes. But in terms of injections to prevent further strokes, are they? What is?
I have to say, I don't know of an injection that will help prevent a future stroke as such. Obviously, if somebody has had a stroke, you do want to try and help that person as much as possible. And even though somebody is pretty badly affected by a stroke, I think to emphasize to people is that there is a lot of potential to recover. And there's a lot of capacity for the brain, of other parts of the brain, to take over the functioning of the damaged, stroked area. And it's an opportunity to start what is recognized as useful treatments in these people. I mean, in terms of preventing further strokes down the line, no particular injection is probably going to help with that. But really, it does come back down to lifestyle modification, identifying the possible cause or causes that this person had a stroke, and treating those things in a proper fashion. So really, whether that be control of the diabetes or high blood pressure, that's the important thing, really.
So I think, it's a very important point for the person who rang in. Her husband is 79, but there's still things that could be done.
This is correct. I have to say, 79. There was a lady I saw weeks ago, 92.
92.
90, and
Wow.
you know, so 79 is a good age to start getting older, maybe, but it doesn't mean that you're old at all, really.
Right.
A lot of times now, you know, you have a chronological or age on picture, but really a lot of people do quite well. And looking at the scan of this 92-year-old lady, her brain looked very healthy indeed, and she had been under no physician, in fact, up until the one stroke she had.
I think that'll be an intriguing program to talk a little bit about the aging process. We did a program a few weeks ago on healthy aging, and we talked a little bit about some of those factors. Remind you, you're welcome to call in on 6524855. I just want to come back. If questions come in about strokes, we can come back to that. But we were talking about epilepsy, and we were talking about the different types of seizures. So I just wanted to kind of pick back up on that. And we talked about different areas of the brain. So you have the temporal area. You were talking about the occipital
lobe seizures,
yes.
And they tend to be quite rare, in fact.
Right.
But so again, these people, they may not realize that it is an epileptic problem that they have initially, because with the vision part of the brain being affected, you do visualize abnormal things. The important thing is, though, that makes you think that this is an epilepsy-driven seizure, is that the activity that happens is very stereotyped.
Right.
And now, what do I mean by stereotype? By that, I mean that it tends to be the same activity that happens time in, time again. So the seizure behaves in a similar fashion.
Right.
Whether it starts with an abnormal taste in the mouth or abnormal deja vu feeling even.
Yes.
It begins in a similar way, proceeds in a similar way, and ends in a similar way. Quite different from the non-epileptic attacks, which can be very bizarre and unusual in their symptomology as such.
So, in terms of, I guess, diagnostic tools, is it the EEG again? Is the main?
Yeah, and so the purpose again, the diagnosis of epilepsy, the history again. You go back to the story.
Okay.
Again, 90% of your diagnosis is really
based on history.
The history.
Anil, sorry about this. I want to take another question. We try to take as many questions. Hello, welcome to Your Health, Your Choice.
Hello, good night.
Good night.
Both of you all. I'm a regular viewer of your program. But I heard the doctor was talking about epilepsy. My father used to suffer with epilepsy. He lived for 80 years, and I thought that $20, and there was a medicine named Rensol from America. And my father used that for about 4 years and never suffered epilepsy again until he died. So I think that was a kind of cure for
Do you have your television on? Okay. I think we've probably lost that call. But I think he was talking about some therapy. I didn't get the name of it. So we could talk a little bit about treatments. I think he was saying that his father, from what I gathered, his father used some treatment and never had epilepsy again. So we were going to talk about treatments. Well, let's just finish the discussion on investigations. You said history?
Well, again, yes. So history really guides your investigations, what tests you're going to do on this patient. And it goes back to the electroencephalogram again, the EEG, looking for abnormal electrical activity in the brain. And I have to say, in the majority of cases, the EEG may not be abnormal, in fact, because even in epileptics, the brain behaves itself for the majority of the time.
Right.
However, you can pick up abnormalities there, and on imaging of the brain, you're looking for abnormalities which can cause epilepsy. And the most common thing is structural abnormalities in the brain. Some people have developmental abnormalities. Some people have scarring that occurs to the brain either through previous strokes or traumatic brain injury. And these scars can act as an epileptic focus on the brain to provoke seizures. So really the reason for doing these investigations is to help in diagnosis. And then you move on to the treatment, the mainstay of which are the epilepsy medications. Now, there are several drugs available.
And I just wanted to talk about, the traditional drugs, because I had a few patients coming to me recently, and, they were asking about new drugs, new therapies, and I said, well, look, I need to refer you to a neurologist, so I might be referring a few patients to you soon, Anil. I mean, the traditional drugs like phenytoin, Tegretol, etc., but there are lots of new drugs available.
There are new drugs. The traditional drugs, I sometimes tell people this, drugs like phenytoin, sold as Dilantin, they're still around because they work.
Right.
You do have to be a little bit careful about which drug you choose for which person. But the old drugs are still there because they are good epilepsy medications. There is no denying, however, that the newer agents, for example, levetiracetam or Keppra, they do have less side effects, and they still allow for good seizure control. There are some new drugs which are not available in Trinidad as well, and hopefully with time we will have them available here. So while it would be good to have people on the newer agents which carry less side effects, there are various limiting factors in this country. No denying that price is a factor.
Right.
But the old drugs, to some extent, do achieve what is desired, and what is desired is really complete control of the seizures. And then, of course, there's combination therapy where you add on another drug. So if somebody's on multiple epilepsy medications. The important thing to emphasize to people with this diagnosis, however, is that the drugs can take you only so far. It is important to remember that if you carry a diagnosis of epilepsy, that you really try and lead as routine a lifestyle as possible, whether that be avoiding sleep deprivation, skipping meals, being cautious not to get any severe infections or flus, and not exposing yourself to strobe lights or video games, or heaven forbid you take drugs that those things are definite no-nos for the epileptic.
I'm just wondering, I mean, with video games and all the computer equipment for our young people being so easily available now, I mean, are the messages getting out, in your opinion, to the schools, to community groups about educating our young people about these risk factors?
I think the message, I think, is certainly out there to a lot of parents, in fact, but whether it reaches sort of the official level of someone in charge talking about these things is not really as prevalent here. But it is clear that these things are risk factors, especially in people who have epilepsy. In fact, if you look at the young population, they've got their phone in their bed with them. They're sleep deprived. They're checking their mobiles or their cell phones ever so often, and this does lower your seizure threshold. In fact, there was a young girl that I saw that she in fact only got seizures when she took the iPad to bed with her.
Really?
So it's important that these things are regulated by the people in charge, the parents, really. And it's important, of course, to emphasize to people with this diagnosis of epilepsy that seizures are not trivial. and there's always a risk of death from a seizure. And epileptics are of course, more prone to unexplained death as well. There's an acronym that goes with that. It's SUDEP, sudden unexplained death in epilepsy.
Right.
So use of these devices, it really should be measured at
Yes.
best, really, for a number of reasons outside of just epilepsy.
I guess good parenting. I know we're talking, it's a medical program, but very often we kind of get into a more philosophical discussion that as parents, sometimes we have to be a little bit more firm with our kids, especially teenagers, because there's so much peer pressure out there that they all have phones, all have iPads, and the thing is, as you're saying, to have the phone at bedtime, and very often we think our kids are asleep and they're checking their WhatsApp messages, etc., which has implications for not just epilepsy, but of course socializing, sleep deprivation, etc. I mean, my wife, who's a teacher, often says that our kids now, their communication skills are being affected by all the technology.
Yes.
Yeah. We only have about 5 more minutes, Anil, and so I just wanted to say that I'm definitely going to have you back on the program if you're going to take the challenge of coming from north down to south. You're a north person. I was just going to say the telephone number, if you wanted to see Dr. Ramlackhansingh, it's 357-5964, 357-5964. I'll just remind you of our number, which is 4824269. So if you miss that number, we can always give you the contact number on our normal number, which is 4824269. Anil, you're based at West Shore and also some areas on the East-West corridor?
Yes.
Right. And people can be referred to you directly?
Of course, yes.
Right, okay. So just closing up with a few, what I want to say is on our next program, whenever we do that program, we're probably going to talk about headaches, which is, in my mind, a headache to diagnose. I find headaches very challenging to diagnose properly. And we're probably going to talk about strokes and maybe Parkinson's, which is another common area. But as we close up tonight, a few take-home messages on non-epileptic attacks and epilepsy.
I think what I want to emphasize to people here is that the importance of sitting down and talking to people and correctly diagnosing people, and the fact that sometimes in life strange things can happen, but it's important to really reflect on the types of lives that we live. And to take the help that is being offered to us to some extent, and to some extent accept that stress can play a factor in our well-being and how we cope in life. And really, a lot of the things that help improve our well-being, it does go back to simplifying things to some extent and ensuring that you do have regular patterns of living and what can sometimes be looked on as a very mundane life, but it really helps promote a healthy and a properly functioning brain to some extent.
Well, Anil, it's been a real pleasure having you on the program. And as I say, we often joke and say, for people in the north, nothing exists south of the Caroni. But I'm glad that you took the challenge of coming down and finding the studio, and it's been really enlightening for me interviewing you tonight. So I just want to remind you again, as we close off our program, we've had Dr. Anil Ramlackhansingh with us, a specialist neurologist, and he can be contacted on 357-5964, 357-5964. As I end, as we often do, I take off my medical hat and I put my pastoral hat on. I want to remind you the number for the Anapausis Center is 482-4269, 482-4269. We also have a website with a wealth of information, www.anapausiscommunity.com. I just want to remind you that's a holistic site where we have the medical center, the teaching arm, and of course the church. I want to leave you with a thought tonight as we lead up to Mother's Day and we look to the end of the year. I've been teaching on a series called Divine Direction. How do we find or how do we get direction from God? And we're a Christian station, and I assume as I'm talking to you that you have a belief in God. I want to remind you that small decisions that you make every day will determine the stories you tell at the end of this year. In fact, who you are today is the result of decisions, very small decisions you have made over the last 5 years or 10 years. So I want to encourage you to make good decisions, make healthy decisions. This is a medical program, Your Health, Your Choice. Dr. Ramlackhansingh has talked about living a healthy life in terms of your brain function. I want to encourage you to live a healthy life in a holistic way, body, mind, soul, and spirit. And when you think about asking God for direction, and I'm a firm believer that God has a plan and he has a purpose for our lives. And one of the things we often say is that when you find that purpose and plan, your life is filled with passion. And one of the important things for me is to be passionate about what I do in my medical career and my family life and in my church life as a pastor. So as we close off tonight, I want to remind you that you can ring us on 482-4269. We're going to have Dr. Anil again with us maybe in a few weeks' time, if he agrees to join us again. And you can look at this program again Thursdays at 1 p.m. and Sunday evenings at 7 p.m. Thank you for joining us on Your Health, Your Choice. We'll be live again in 2 weeks' time. Thank you and good night.
The preceding program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.